Hi, this is Dr. Crawford. I've been talking about the breast cancer meeting at Harvard Medical School. Today I'm going to do something a little different. I'm going to focus on a specific type of cancer, invasive ductal carcinoma, no specific type. So what do we mean by this? This is a carcinoma of the breast where the type of cells involved have multiple characteristics. Now, before I get started, I want to emphasize that the purpose of this report is to inform and educate only. I am not offering any medical advice, and please consult your physician if you have any questions about breast cancer. So let's define what this type of breast cancer is. Sometimes it's also called not otherwise specified. It is the most common type of invasive breast cancer, responsible for about 75 to 80% of cases. It is an invasive carcinoma, meaning that it has invading properties in the surrounding tissue, with evidence of a specific cellular origin, which is called the mammary epithelial cell. It is a diagnosis of exclusion. So it lacks some of the features that would be used to classify it as a specific subtype of breast cancer, and has multiple features. It arises from an epithelial cell, an early stem cell of epithelial type at the terminal duct lobular unit, okay? So this is true also of lobular and other types of breast carcinomas. In terms of the prognostic factors, in terms of what is the clinical outlook for the patient, the age of the patient, the tumor stage, lymph node status, and some other aspects of the tumor, such as histologic grade, clinical biomarker profile, and gene expression signature, all are important in making a prediction about the clinical course of the disease. The way in which these patients are treated is that the tumor is removed by surgical excision, with or without radiotherapy, depending on the patient, systemic chemotherapy, or various targeted therapies, which would be decided between the patient and the physician. And there are various guidelines now requiring the assessment by standard breast biomarkers, such as estrogen and progesterone receptors, as well as HER2. So this is a big topic, lots to it. Today's talk is introductory. Just want to go over the important components of this type of cancer. Now, this is the first reference that I'm using. One of the authors here is a very famous cancer researcher, Mina Bissell, and the title is Three-Dimensional Culture of Human Breast Epithelial Cells, and she's done quite a bit to study this disease in the laboratory. And this is the overview. Invasive ductal carcinoma, again, no specific type, and it is sometimes abbreviated NST. And this is another reference that I'm using to describe and discuss this with you. You can research these references as well. So I want to start with a brief diagram, just giving you a general overview. This is from the Bissell paper. And this shows you the overall structure of the breast. Here's a nipple, and then at the interior we have the muscle and fat pads, and then we have the important structural component, which is the milk-producing compartment of the breast, consisting of the lobules and the ducts, which conduct the milk to the surface. Now, If you look at a microscopic view, this is obviously a cartoon of just one of these lobules, you'll see this is what it should look like. So it's surrounded by cells, and then there's an open region in the center that connects to ultimately to the duct. This is an electron micrograph, a very, very high resolution, where you can see the molecular structure inside that lobular tissue. And this shows you some similarities between what we would see inside the breast in vivo and in three-dimensional culture, where you can study it outside the body. And so you see a very nice organized structure that is, this is the lumen, the opening, and then this is the cells surrounding the lumen. So this is an important tool for study in cell culture. So this group of breast cancer is a large group, heterogeneous, meaning that there's a lot of different characteristics in different patients. It lacks features that would be diagnostic, as I mentioned a moment ago, of a very specialized type of cancer. So therefore, there is a range in morphology or the structure or lack thereof of the tissue, the grade, which we're going to be talking about what the grade is, the biomarker profile, and the molecular subtype, as well as clinical behavior. So it's quite a diverse group. And it is called invasive breast carcinoma, not otherwise specified, sometimes simply referred to as invasive ductal carcinoma, arising from the ductal tissue within the breast. Now, etiology means the cause of the disease. And again, this could be a lecture or even a book of its own. I'm just going to very quickly go through this. And as we see in most cancers, there's no one specific cause. It's what we call multifactorial. But these are some of the risk factors that have been identified. It is multifactorial, complex, but there can be a hormone involvement, reproductive factors, environment, and genetics all playing a role. And it is thought about 40% of this risk in postmenopausal patients may be modifiable, which again goes into the area of prevention. What are important tools for prevention? What do we know about it? So that's, again, something that I'm very interested in, but it's not an exact science very often to really identify exactly what would be able to prevent it in a particular case. However, we know some general factors. So there are some hormone-related risk factors, prolonged exposure to estrogen, such as having an early menarche, late menopause, nulliparity, meaning not having children, older age, first child, etc. Postmenopausal women with obesity and estrogen-producing ovarian tumors, which would be a specialized group in terms of risk factor population component. Women using a combined hormone replacement therapy with progestins or estrogens by themselves alone, which is normally not done. Much study with oral contraceptives, but not anything conclusive, so there's really no obvious risk here. It is associated with an increase, the hormone factors are associated with an increased risk of hormone receptor positive breast cancer. And there's also some evidence of some of these factors having a risk in the triple negative breast cancers as well. So this is just very, very general and nothing really conclusive here. Now, in terms of the genetic risk factors, just want to move this over a little bit if I can. Okay, I got to go back one slide now. Hopefully I can. Back one slide. Okay, I'm not sure I can. Well, at any rate, there are certain genetic risk factors which include the BRCA gene mutation, but overall, genetic risk as a single determining factor for the cause of breast cancer is very low in and of itself. And again, in a future lecture, I will talk about genetic factors and genetically linked breast cancers, which are a small group but a very important group. In terms of environmental risk factors, very interesting, again, something I would like to talk about separately at some point. The rates, for example, in the United States are 5 times higher than in Japan, Taiwan. Also higher in Northern Europe, lower in Asia and Africa. We don't know why, but there's a lot of interesting epidemiological work, differences in environment, differences in lifestyle, differences in diet. So again, and one of the telling issues is that when individuals from areas of the world where the incidence is lower migrate to this country and adapt to our lifestyle, their risks go up. So clearly there is a connection here, which we will talk about in the future. It appears that excessive alcohol consumption could be linked. Adult dietary soy foods and carotenoids seem to have a protective effect. Physical activity seems to have a protective effect. But whenever you start to talk about prevention and protection, you have to keep in mind that this is a disease with multiple causes, and each individual is different, and the individual factors and the contributions of each factor to the development of the disease may differ. So it's very hard to make blanket statements, perhaps except to say to be in overall as good health as possible. But we will take apart some of the risk factors and some of what have been termed prevention factors in future conversations. Some of the demographics that we know about is female, being a female, and at older age, most common risk factors for breast cancer. Also having had a cancer in the opposite breast or endometrial cancer. High level radiation exposure in women who have had other cancers early in life. And mammographic density, high density breasts, that's a big area of conversation right now, and we'll talk about that in a future lecture as well. Now, I just want to, this is an overview talk here, so we just want to give you a general idea of what's going on, the various stages, and a person who is diagnosed with breast cancer is going to be told what stage it is, and it's important to have an understanding of that. And if we look at this, they are divided among 4 stages, 1, 2, 3, and 4. Stage 1 is the earliest stage. Sometimes there's even a stage 0, which is called DCIS, where there's a tiny lesion inside the duct and shows no characteristics of invasiveness. So that may be the earliest stage. But stage 1, it would be where the tumor is clearly smaller size, confined to the breast, and there's no lymph node involvement. Stage 2 is also considered early disease. The tumor is somewhat larger, greater or equal to 2 centimeters in diameter, and may have spread to various axillary nodes. So it may be a node positive, early level, larger size tumor. This is very general, but just to give you an overall idea. So those aren't the only criteria here, but just to give you a very quick overview. Stage 3 would be called locally advanced. This is where you have spreading within the breast. So for example, to the chest wall, etc. So, and there would be some involvement of the mammary lymph nodes. And then finally, stage 4 is advanced or metastatic disease, where the tumors have been detected, tumor cells at distant sites in the body, which could include the bone, the liver, the lungs, and the brain. And of course, there would be lymph node involvement at this point. And so this is just a very general catalog, and there's a lot more that goes into staging than this very simplified criterion. We know so much more about cancer and breast cancer than when these original guidelines were established, but this kind of just gives you a general reference, and we're going to be going into much more detail as to what these stages really involve. Now, this is a mammogram, and this is showing an invasive breast cancer. So you'll notice the tumor here, and what's really informative is that these lighter regions show the spreading of the tumor in an invasive, moving away from its original site of origin to invade the surrounding breast tissue. So it's a very clear view of what a spreading invasive breast cancer could look like. So again, we talked a little bit, and again, I'm just going over this very quickly, but to give you an overview, prognostic factors. I mentioned that there's a number of factors that will be taken into account in order to determine what treatment decisions to make and the likelihood of the disease being controlled readily. So the patient age, again, that's there's sort of a lower age group that has risk factors, and then a postmenopausal age group that have other risk factors. So the age is important to take into consideration. The stage is going to be determined in part by the size of the primary tumor, as well as whether or not the cells have spread to the lymph nodes, which would indicate they're able to get beyond the original site and may start at some point, if not treated, to spread throughout the body. Now, histologic grade is a separate factor, and that will involve looking at the tumor cells and the tumor directly to see how much abnormality within the tumor cells is observed and how much disruption of the structure of the tissue. So we're going to get into that a little bit. And then, of course, lymphovascular invasion, when you've moved over to the conduction system within the body, a higher risk of recurrence and distant recurrence. And now, added to that, we have a whole series of biomarkers that have been identified that have very important, provide important information on diagnosis and treatment. So, for example, in general, again, it's very hard to generalize, but hormone receptor expression, such as progesterone, estrogen, associated with better short-term survival. HER2 expression, there's anti-HER2 therapy that is given now, and that results in improved survival within this group. And looking at what's called the gene expression signature, the genes that seem to be involved in either the origination or propagation of the tumor, the various signatures can correlate with different survival and prognostic profiles. So again, just very generally, the treatment, surgical excision, either by breast-conserving surgery, lumpectomy, or mastectomy. That again is a decision made based in an individual basis by the medical team and the patient, taking into account the specifics of the tumor in an individual. With or without axillary lymph node dissection, meaning that if there's evidence of cancer cells in the lymph nodes, then some of these may be removed. If there is no evidence of cancer cells in the lymph nodes, then they will not be dissected or removed. Now, also, this is frequently associated with radiotherapy to the breast after lumpectomy or mastectomy to reduce the likelihood that the tumor will return in the breast. In addition, there may be systemic chemotherapy, either neoadjuvantly in conjunction with surgery or post-surgically, in order to make sure there's no systemic spread, and also to assist the body in blocking any subsequent growth of the tumor within the breast. In addition, there's a whole class of targeted therapies that may be prescribed based on hormone status and HER2 status. So these would directly affect particular pathways that are abnormal within the cancer and responding abnormally to hormones. So you want to block those hormone-mediated growth pathways in order to prevent disease recurrence. Okay, so how do you make all these decisions? That will be based on the size of the tumor, what the cells look like, biomarker status, genomic risk assessment. There's all kinds of scoring that's now done, looking at particular genes that may be associated with higher or lower risk for disease progression, the location of the tumor, various aspects of the patient, age, and other situations that may be occurring physiologically, the BRCA status, whether it's a heritable breast cancer, and then any history, patient history that may be involved in terms of either risk factors or patient decision making in terms of what choices, where that's possible. Now, staging is an important aspect of looking at how advanced the tumor is. Breast cancer can be staged from 0, which, as I mentioned before, such as DCIS, ductal carcinoma in situ, where this is a disease which is so localized within the ducts or the channels within the breast that it appears to be non-invasive, all the way up to stage 4, which is metastatic disease. And this, of course, is a prognostic factor. The higher the stage, the more severe the disease, and the lower the stage, the better the long-term result. So the level of intervention and treatment protocol will certainly depend on this. Now, just to give you an overview of what we mean by stage, this can be the pathologic stage, and this would be done at the time of surgery. So there's 2 ways of staging. When you come in, there's a diagnostic clinical stage that is determined on a clinical exam, etc. And then at the time of surgery, there's a more detailed possible assessment because you have more of the tumor to look at. So this will take into consideration the characteristics of the tumor itself, T, and the presence of lymph node involvement, which is N, or organ metastasis, which is M. And these are taken together to give you a TNM score. The lower the score, the better. So the pathologic stage, T stage, would be T0 to 4. The N stage is N1 to 3. 1 lymph node or up to 3 or more lymph nodes, and M01. So either it's metastatic or not, either it's not metastatic, which is a 0, or metastatic, which would be 1. And overall, these TNM values are combined to form a final overall pathology stage of 0 to 4. And there are other histologic examinations that can be done with specific antibodies, DNA testing, which also can contribute to this type of diagnosis more at the molecular stage. But here we're talking more specifically about general pathology and how it can be assessed. There is an American Joint Committee on Cancer published a revised protocol in 2018. So that is generally what's used as the criteria standards. This is just another view where stage 0 would be confined within the duct. Stage 1 is a localized small tumor, generally with no lymph node involvement. Stage 3, larger, and there may be some lymph node involvement. Stage 3 is often larger yet, with local spread shown here, as well as some lymph node involvement. And of course, stage 4 is metastatic disease. And the goal is to detect breast cancer at the earliest possible stage. And that, again, we're going to have another conversation about the newest tools and techniques that may accomplish this. The histologic grading is based on what's called the Nottingham Modified Blumen-Richardson Score, which has been around for a long time and is modified over time as more criteria are established. And this involves tubule formation. So 1 to 3 points. If there are greater than 75% of the tissue in looking at the pathology has tubules, which are normally found within the breast, then you get a 1 point, which is good. If between 10 and 75% of the normal amount of tubules within the breast, it's a 2 point. And then less than 10% of the tissue still has that tubular structure that normally would be found in the breast, then that's 3 points. So again, this is talking about the overall tissue and how disorganized or disrupted it is by the growth and spread of the cancer. Now, the next is called nuclear pleomorphism, which is how structurally normal or abnormal the nucleus is. The nucleus is where the DNA is located. The larger it is, and the more abnormal in structure may indicate abnormal chromosome complement, and also may indicate abnormal cell division. So you take a good look at the nuclei as well. So here you have 1 to 3 points as well. So if the nuclear size, shape, and number are small, they're regular, they're uniform, they look like fairly much like normal ductal epithelial cells, then you get 1 point. If there's a moderate increase in size and variability in overall appearance, 2 points. If there's large nuclei, marked variation from normal nuclei, and seeing some vesicular chromatin, etc., you're going to get a higher score, 3. And then we have a mitotic count. How many of the cells look like they're actively dividing in that whatever the field area is? So 1 would be the lowest amount of cell division, 3 would be the highest, obviously, higher cell division, greater growth, and that's not good when you're in the tumor area. So you're going to add those 3 points, tubule formation, nuclear pleomorphism, and mitotic count, and you're going to get a number of points. The lowest you could get is 3, where you get 1 for each, and 3 to 5 is called a grade 1 cancer. 6 to 7 combined score would be a grade 2, and 8 to 9 is a grade 3. So even though each patient's tumor is somewhat different and unique, it's good to have some general parameters in order to make treatment decisions and to compare and contrast among patients to get a better indication overall how patients with different levels and stages and grades of cancer are responding to various approaches. So it's important to have a general criteria while keeping in mind the uniqueness of each patient. And the histological features where you have invasive breast cancer, no specific type, will vary because it is no specific type. So it's going to, be something that's done on an individual basis. The margins are important. So is it a margin that is very well separated from the rest of the tissue, which would indicate low invasion, or is it highly infiltrating, permeating the surrounding tissue, looking as though it's spreading, as in that first jagged-edged, literally sending out projections in that first mammogram that I showed you. That would be a poor margin that are highly infiltrative. And then you have certain architectural features that would be recognized by the pathologist, indicating various types of lobular carcinoma. And then again, tubular formations. If it's a well-differentiated tumor, meaning it looks a lot like the original tissue, that's a good sign. The more disrupted the tissue structure is, the fewer the tubules, the higher the number for that. So the grade, therefore, is going to be a prognostic factor. What does a tumor look like? What's it doing inside the breast? Does it look like it's spreading? How abnormal is the tissue? Does it look invasive? Does it have a margin? So it's a broad generalization, but low-grade cancers assessed in this way tend to be less aggressive than the high-grade cancer. So it's very important to determine the grade, because this is going to be very important in making treatment decisions. Now, when you're looking at the microscope histologic tissue description of the IBC NST, we see a wide spectrum of differentiation, lots of differences, lots of unique, not totally unique, but varying patterns within the tumor. So some tumors will be at the end of the differentiation spectrum, but there's nothing so specific or common among the tumor cells or the structure of the tumor within the tissue, so that we can classify them as a special type. So again, diagnosis and classification is an ongoing science. The greater the amount of information that can be obtained using newer and newer, more precise methods, the better we can make these classifications. And again, the mitotic figures, in other words, how the cells are dividing. There may be almost none, meaning it probably is a slow-growing cancer. That's not the only parameter that would be assessed. Nevertheless, there can be two distinct growth patterns: large and solid nests, which would be sort of cells multiplying and forming a group or a cluster, a grape-like cluster, or more of a syncytial, moving outward, spreading infiltrative growth pattern. So there again, that will be different for different patients. Tumor is characterized by small cancer nests that are show marked fibrosis or calcification, abnormalities of the stroma. That's also very often seen, as well as calcification and necrosis, or patches of dead tumor cells, which indicates a high growth rate and inability of the tumor to completely support its own viability. Okay, and some of this is a little bit detailed. Again, this is what they're trying to say is, is this really no special type, or is it a subtype pattern? And clinicians are very often able to take a percentage viewpoint of various aspects of the tumor to make that clinical decision. I wanted to show you what some of this looks like. This would be an example of, this is the pathologic tissue, which, so it'd be from the patient's tumor, and it's stained with a very common stain called H&E, hematoxylin and eosin. And this would be called a low-grade invasive ductal carcinoma with tubular features. So it shows sign of invasiveness. You can see the tumor cells are darkly stained, more prominent nuclei than normal cells. and they you can see that there is an invasive pattern spreading and moving around within the tissue, but there's lots of tubular structures within here as well that maintain their normal appearance. This is a cross-sectional view, but the tubules appear to be highly differentiated, which would be indicative of tissue that has not deviated significantly from normal. This one shows infiltrative small nests and tubules with small cells and low mitotic rate. So the cells look very small here, which is good. They look fairly uniform in overall shape and size in terms of the nuclei. These are the fat cells, not any invasion of the fatty tissue within the breast. So they're not enlarged. They don't look like they're dividing too much. But they're infiltrated. They're moving around, and they're small nests around the tissue. Okay, so again, some of the descriptions that would be assessed would be the how normal or abnormal the cells are there lots of differences among them? The size of the nucleus, is the nuclear margin clean? Etc. And cellular discohesion, meaning the cells are not attached to one another as they normally should be, higher number of mitoses, necrosis, or cell death. All of that is going to be at the level of the individual cells versus, so that would be the cytologic tumor grade versus the histological grade, which refers to the tissue as a whole. Now, this is a more advanced, probably considered a grade 2 tumor. The nests are much larger. The nuclei, you can see them more prominently in many of the cells. Therefore, there are more of them, they're larger, the nuclei are larger, the cells have a little bit more of a pleomorphic appearance, and there's more disruption of the structure of the breast overall. And so this would be a higher grade. This is yet a higher grade. So here you're probably in a grade 3. You're seeing within the tumor lots and lots of these very large nests infiltrating the various tissues. The nuclei are somewhat enlarged. And they're really, you can see that more and more of the breast tissue is being consumed by these nests of expanding cell masses. And that certainly is and a compression of the more normal regions, indicative of a more locally advanced cancer. Now, this would be, again, a high grade cancer. The cells are sort of all over the place. Okay, so you can see the tumor cells invading all over the place. You don't see many tubules. It's quite disrupted overall appearance histologically. And there's a lot that are sort of getting right in the area of the fat tissue, looking like they're really going to be taking over the tissue as a whole. Fortunately, this is a little small. I apologize for this. This is, again, similar to the previous one, haphazard distribution, just a general overall differences in cytology and differences in the histological presentation of the cancer. This would be an advanced cancer. Sheets of large, pleomorphic, so in other words, many different shapes and sizes of tumor cells, with some zones of necrosis, and you really wouldn't be able to tell almost what tissue you're dealing with here. Everything is gone. You can't see the tubules, you can't see the fat cells. Adipose tissue is hard to see, lots of invasion. So this uniformity, massive infiltration of the normal structure of the breast by these growing cells indicates locally advanced breast cancer. Okay, again, yet another image of that, high grade, abnormal nuclei. You can just see how different some of them are, more larger, darker staining, and again, breakdown of the entire structure. Now, this was a nice slide because it shows, in addition to the invasive ductal carcinoma over here, sort of on the left, there's an area that's more normal. So, you kind of get a sense of the more normal structure of the breast versus over here where it's really much more abnormal. This is an invasive carcinoma, which is staining heavily with a brown stain. Now, this is a stain that specifically recognizes a cell surface component called E-cadherin. And when you get lots of E-cadherin staining, this is a cytological marker for both invasive and in situ carcinoma, and shows that there's some ductal differentiation. Because that is associated with the production of this particular protein. So where you get lots of E-cadherin, then you have, it indicates that the normal structure of the breast is somewhat conserved. Now this is showing you an invasive ductal carcinoma all through here, with an adjacent focus of tumor within a lymphatic space. So these holes are the lymphatic tissue that lymphatic channels, that run through the breast tissue. And now you're seeing this invasion of some of the channels within the breast. So that would be the first stage for the spread to the axillary lymph nodes. Now this very pale slide shows a loss of myoepithelium, which is a muscle-like epithelial tissue found in the breast, and that should stain with a specific marker that recognizes that particular protein. But it doesn't. It's not staining much at all. Most of this is not staining, and therefore that indicates that you're breaking down the normal structure. The normal proteins found within the breast are no longer there, and that would be indicative of a higher grade invasive carcinoma. So I will end my talk here. I hope I've given you an idea of what we mean when we talk about invasive breast cancer, no specific type, large group of breast cancers that affect a high percentage of women. And as we go through future talks, we'll speak specifically about how these tumors are treated and how patients respond with this type of breast cancer. So thank you for listening. I'm Dr. Crawford, and I will be back soon.